Talk a little bit about the epidemiology indications and most importantly, the contraindications. I'll touch on the workup. We'll talk a little bit about the implant design and some outcomes, and I'll give you some surgical pearls. So isolated patellofemoral arthroplasty is relatively uncommon compared to tricompartmental or bicompartmental osteoarthritis. However, it does account for enough of a patient population that we need to think about this. Women account for about 3/4 of the patellofemoral arthroplasties in most reported series, and this is likely related to the malalignment dysplasia that's more common in women. So the indications for patellofemoral arthroplasty are just that: isolated patellofemoral arthritis. This can also be post-traumatic arthritis and dysplasia without significant maltracking. Although I think you can also consider patellofemoral arthroplasty in dysplasia cases where maltracking has been corrected. It's unclear what age is actually appropriate. There's varying opinions on this. There's some authors who advocate that this is more appropriate for a younger age patient population. Some will advocate for more elderly patients. However, there's no data that shows any difference in outcome by age. I think the most important part of this is you need to factor in the revision rates and the patient's acceptance of the fact that they will need to have a revision down the road if they get it rather young. I think the contraindications are the most important part to successful patient choice for this procedure. Obviously, inflammatory arthritis, chondrocalcinosis, ligamentous insufficiency is an important one. As I mentioned before, significant malalignment, any tibial-femoral chondrosis, although there's some debate on which degree to accept. However, I think you should accept a KL grade of 2 or less in order to do this procedure. A flexion contracture is a contraindication. Any kind of pain syndrome, fibromyalgia or chronic regional pain syndrome is also a contraindication. It's unclear in literature how much Alta or Baja to accept for this procedure, although I think you should be cautious at any sort of extreme Alta or Baja with these procedures, particularly at extreme Alta. It's unknown whether or not what an appropriate BMI cutoff is for this procedure. However, I think in the morbidly obese, you should certainly avoid it. And there are some studies that show that patients with poor mental health scores do not do well with this procedure. So the workup is a classic workup. You're looking for anterior knee pain that's worse with stairs and loading the patellofemoral joint. Physical range of motion, you really want to assess any sort of maltracking, including the J sign. And you really want to be cautious if there's signs of maltracking or global laxity suggesting something like Ehlers-Danlos. You also want to be cautious if there's any sign of tibiofemoral arthritis on the workup. Standard imaging includes AP lateral Rosenberg and patellofemoral views. I think if your clinic is able to support it, doing a full-length film is very reasonable in all patients, but I think it's necessary if you suspect any maltracking. A CT scan is also part of a maltracking workup. MRI is rarely necessary. However, you can confirm cartilage quality and ligament integrity in patients who you're hesitant about performing this on or who don't want to accept a total knee replacement. Important considerations for patellofemoral arthroplasty include implant design. The first generation of PFAs were inlay prostheses. You can think of these as resurfacings. They essentially were flush with the native trochlea. In general, these prostheses had poor outcomes. However, newer generations seem to have slightly better outcomes. The second generation of PFA were onlay. This is a replacing prosthesis, so you're replacing the patellofemoral joint just like in a total knee arthroplasty. These tended to have significantly better outcomes, likely due to the ability to control rotation. This slide shows this very clearly. On the left is an inlay design, on the right is an onlay design. You can see in the CT scan on the left that the inlay design forces you to place the trochlear component in line with the native trochlear anatomy, which causes it to be slightly internally rotated, whereas the onlay design, you can control rotation, externally rotate, and thus account for maltracking and dysplasia. So the big question is do these do any better than total knees? Why not do a total knee? And it turns out that good randomized control trial shows that especially early, they seem to do better than total knees, so very reasonable to consider. If you look into this study, this can actually serve as a good exclusion criteria for you. Otherwise, other outcomes on longevity are kind of all over the map. You can see this here with different functional outcomes showing very much a mixed bag. However, some patients and some implants can do very well. And it's important to counsel patients that the longevity is actually not particularly high. In registry studies, it seems to show a 30% revision rate at 10 years. However, it does seem that this revision rate over time is going down as we choose different implants. So some surgical pearls. Every patient is consented for a total knee arthroplasty in case you run into other issues. You need to make a full exposure of the femur. This is not a minimally invasive procedure because you need to see the femur to put the implants in the right place. Some authors advocate a lateral approach. However, I strongly disagree with this due to the high predicted conversion rate and the difficulty with this. So the most important part of this is placing the trochlea in the right position. You really want to avoid extension. You want neutral or slightly flexed, as in this picture. You do not want extended, as in this picture, as this will cause major problems, both pain and maltracking and clunk. You want it to be slightly externally rotated for on-leg designs. And then essentially medial, lateral, proximal, distal, anterior, posterior, and varus and valgus, you can all will largely be dictated by your implant. However, the goal is that you want a smooth transition from the implant to the cartilage surface, and you don't want to impinge on the notch. So for the patella, my preferred technique is a freehand resection. I think this actually serves me generally well because I can really see the patella and see what I'm cutting. Calipered resection has been shown to create a more even resection, and you want to restore what you think is the native patellar height. However, you want to have a minimum thickness of 12 to 14 millimeters remaining, and it's okay to build up with cement in order to keep a thickness that's safe and lowers the risk of patellar fracture. If you're having a difficulty with tracking, you can release the lateral synovial fold or do a small lateral release around the patella. However, a large lateral release you may need in some cases. Post-op is essentially an outpatient procedure. Weight bearing is tolerated, but cane for safety. And I use all of the standard total knee arthroplasty pain protocols. In terms of revisions, one of the things that makes this possibly a staged or intermediate procedure for some patients is that the outcomes of revisions tend to be closer to a primary total knee than they do for medial and lateral unis. Thus, I'm more, I can go to this procedure with a little bit more confidence, even if I know that the patient may need a revision down the road. If you're going to do a revision, there's a case, patient with a prior patellofemoral arthroplasty a couple of years ago, had a couple of arthroscopic procedures for catching and clunk. However, because the trochlear component was extended, this was not going to be fixed. Then we were able to perform a primary total knee arthroplasty with a good result. I do think when you're performing a primary total knee, you do need to go to a PS prosthesis due to the bone loss in the trochlea. Future directions include robotics, navigations, patient-specific cutting guides. However, none of these things have been shown to make a big difference at this point. I also think there will be a better understanding of specific exclusion criteria in the future. So I think these are good procedures for the right patients. I choose an on-lay design. I think that has more reproducible outcomes. And patient selection and surgical techniques are critical. Happier patients and happier surgeons. Thank you.